Folks, I I'm so excited to introduce our guest, Dr. Troy Brennan. I've known Dr. Brennan for many, many years, and seen him throughout his career, which is really quite remarkable. Dr. Brennan is an adjunct professor of health policy and management at the Harvard T.H. Chan School of Public Health. He's also a former professor at the Harvard Medical School, and he's the former chief medical officer of a small company called CVS Health that you may have heard of. Prior to that, he was also an executive physician at the Brigham and Women's Hospital for many, many years, where I first met him. I can tell you that his reputation in Boston medicine was just stellar. And it, again, just such an honor. And Troy, I just want to say we're gonna talk about your book, The Transformation of American Health Insurance on the Path to Medicare for All. And folks, for those of you who are looking at the video, here's a copy of the book itself. Troy, I just want to say I'm about three-quarters way through the book. I want to read it a second time. It is just one of the best, if not the best book I've read on American U.S. healthcare. It explains so many things that I really didn't quite understand. And I have to say, you have a point of view, which you make very, very clear throughout, but you also present the material in an unbiased way. So I found myself agreeing with you sometimes and then disagreeing with you sometimes, but always appreciating the information you laid out in front of me. So again, just thank you for this amazing book that you've recently published.
Well, thank you very much. That's all very nice to say. And that's kind of how the book was intended to be, explain things that are sometimes arcane in the American healthcare system and also try to argue a point about where things are going. So,
Well, I hope you don't mind. And with all due respect, I'm gonna disagree with you on some things, but I'm excited, super, super excited to have this conversation. So many questions, I have a page of questions, but let's start off really basic with what is the point of this book? Why did you write this book on the path to Medicare for all, the transformation of American health insurance? What's your big idea? What are you trying to get across to folks?
well, as we discussed, so I've seen the healthcare system from a lot of different positions. One is a sort of practicing physician for about 20 years here in Boston, and then as an executive at a big health system, and then as an executive at an insurance company, and then as an executive at kind of a conglomerate, more vertically integrated organization, which is what CVS Health became. We had retail clinics, we had retail pharmacies, we had primary care. We had an insurance company and we had a large pharmacy benefit management company. So I felt like I had a kind of interesting view on the healthcare system, having seen it from various different sort of points of view. But I was also impressed over the time. I mean, I think I retained sort of, I was a professor, as you mentioned, at the medical school and the School of Public Health at Harvard for about 20 years. And I retained that kind of intellectual curiosity. And I think the major point of the book is just that there are forces outside of the healthcare system. They're sort of pushing the healthcare system along in a particular direction, and that direction eventually sort of leads to the government having a much larger hand in the overall financing of healthcare, and specifically that the employer-based approach probably doesn't make much sense long term, unless there's really dramatic changes, simply because there's no control on the costs anymore. And eventually, I think the companies will begin to sort of look to the government to take this burden off of them and have the government take the lead.
What, so you're talking about Medicare for all, sort of, or actually, I think more precisely, and correct me if I didn't get this right, but in the book, it's really more like Medicare Advantage for all. Is that correct? And could you explain that to our audience?
Yeah, I eventually get to the point, sort of at the very end, of saying, it's a dealer's choice between sort of, it's all Medicare for all. But the question really is, do you leave the private insurance companies in the game? That's a Medicare Advantage approach. Or is it something that's basically a single payer? That's the traditional Medicare approach. Right now, we're about 50-50 with,
Hmm.
probably a small majority of people in Medicare having the private approach, Medicare Advantage. And I think there are attributes to both approaches. And I end up saying, I think that the easier way to get there is
Hmm.
through a Medicare Advantage approach. It's less disruptive, and you can think about sort of what a transitional phase would look like if you use Medicare Advantage. But there are reasons why one might choose to try to go to a single payer program. I
Hmm.
just think politically that's very difficult. It may be where we end up, but I think if the insurance companies kind of learn to behave in healthcare a little bit better than they have over the course of the last 30 or 40 years, then they probably have a role going forward. But if they don't, then I think we'll go to a single payer.
What is when people hear that Medicare for all, whether, like you say, include private insurers in there, like a more Medicare Advantage plan, or eventually go to a single payer model that's government run. I think, initially there's a lot of, kind of political tension around that, the whole notion of, socialized medicine. And I'd like you to speak to 2 points. One is, what's your thought about that? So if someone just, literally kind of, I think it's almost knee jerk at this point, Medicare for all, socialized medicine, going to take away people's ability, their freedom to choose, et cetera, et cetera. How would you respond to that? And can you also let us know what's the current problem that this would fix? Why would that be better than the system we currently have in place?
Mhm. Well, if I go to the second question first,
Mhm.
the insurers have long had a series of different kind of cost control approaches that they've taken, some of which have been relatively progressive, many of which have been relatively sort of regressive, in the sort of economist use of those terms. So they do prior authorization, they negotiate for rates, they design programs to try to combat moral hazard by having people spend out of pocket for certain things. But almost all of those have sort of reached the end of their run. Prior authorization is a great example. Prior authorization is worth 4, 5, 6% in terms of total healthcare costs, the average insurance company, but it's under attack and they've overused it. And, it's hard to sort of see how that persists as a weapon. And another thing that employers have done with their insurers is they basically put more and more of the burden on individuals in terms of out-of-pocket costs, so-called high deductible plans. But that's sort of reaching the end of its line. The federal law defines how much further that can go, and it's not much further. So, and the biggest way in which insurers really tried to control things was by negotiating rates. So when I
Mhm.
was at Partners Healthcare in Boston years ago, now called MGB, I was in charge of negotiations with insurers. And so
Mhm.
we would say, we want this amount of pay, and the insurers would say, you're going to get this amount, and we'd sort of negotiate. But those negotiations are now basically controlled by the providers. The insurers are consolidated from an antitrust point of view, but the providers are much more consolidated. And so that's what's happened to healthcare costs on the employer side. So now it's two, 2.5, 3 times as much the hospital or the doctor
Mhm.
gets paid by the commercial insurer as opposed to sort of Medicare. So eventually, I think you have to go to rate setting, and only the federal government can really do that kind of rate setting. And that's why there's a bargain to be had for employers moving from their own insurance plans to a Medicare Advantage plan they would buy, simply because the rates of payment are going to be half or a third of what they're currently paying. So they'll need that. And then you see polls
Mhm.
today by employers who say that 90% of them say the government's going to have to take a larger role. They're not recoiling from socialized medicine. So to go to the other question about socialized medicine,
Mhm.
a single payer program would be, in quotation, socialized medicine. The government
Right.
would pay everybody. It'd be, people usually think of sort of a British system in that regard, where the NHS pays everyone and makes all the decisions. But people don't really talk about the exchange population, the exchange markets in the Affordable Care Act today. One that's so much under discussion today about what the federal subsidies are going to be. People don't refer to that as socialized medicine, and people who are in it don't feel like it's socialized medicine, but it's very similar to what you might see if you had a sort of universal Medicare Advantage approach. The third factor that will come into
Mhm.
play and I don't know how this resonates with sort of the notions of socialized medicine, is that you would basically then also get rid of Medicaid over time and pay everybody the same. It really reflects horribly on us as a healthcare
Mm.
system and a society that, people who are poor, their doctors and their hospitals get paid less than people who are over the age of 65. So by moving to a single program, you fold Medicare and the Affordable Care Act, exchange populations into that. And you'd also be able to get some administrative uniformity. So there'd just be one payment system and not literally thousands of different sort of revenue cycles out there. So you get some administrative savings associated with it. So for all those things, I think people would be all those reasons, I think people would be willing to say this is relatively sort of similar to what I had before. I don't feel like I'm now in the Soviet Union or something like that with socialized medicine.
Right. I think that's a great point. And I think you do talk about this in the book a little bit, but it is, well, let me ask you the question. It feels like we're coming to sort of a tipping point. Here in North Carolina, where I live, two-thirds of employees are have high deductible health plans. So that means that they have to pay, they and their families have to pay for care until they reach that deductible amount, which can be typically in the thousands. And so essentially, you're uninsured for the first few thousand. And at least from what I've read, somewhere around 60% of people who have high deductible plans can't actually pay that amount. It's a significant amount of money, and it continues to get, premiums go up, et cetera, et cetera. Um, do you think we're, at some sort of, or how do you see where we are right now in healthcare? How do you see affordability? How do you see the temperature, and with elections coming up in the next couple of years, what do you see happening? What do you see that direction
Yeah,
going?
I see. I think when people are underinsured, and you've got the statistics exactly right. I mean, usually we talk about sort of people have the free cash in the average or median free cash that individual households have is somewhere between $1,500 and $2,000. They don't have a lot of money in savings. And it's a fraction of what many of them face when they get into a high deductible plan like that. And so when people face those kinds of out-of-pocket costs associated with their insurance, or what this large Affordable Care Act exchange population is going to face as the heightened subsidies that the Biden administration put in place come off, that makes them very dissatisfied with their elected representatives. They feel like government should not be allowing a situation to develop in healthcare where people are basically having to go bankrupt in order to get the
Hmm.
care that they need. And so that's a
Mm.
really strong and very tangible notion of affordability. And it cuts, to the quick because it's healthcare affordability. And so I think it affects the way that people vote. And I think that, as a result of that, you probably see the voting population moving more to the left towards Democrats over the course of the next couple of years as a result of things that the Republicans have done. And the Democrats will pick up on these issues because they know that affordability in healthcare is really an important thing in terms of them getting sort of reelected. So, I try to say in the book, a friend of mine, an old
Mhm.
friend of mine, Jerry Kassir, who is the 93 years old now, but who is the editor of the New England Journal of Medicine,
Mm.
was he said you don't want to write a book where you've got predictions, and but I said still I have to predict, and so you've got to look past
Yeah.
sort of Biden, Trump, sort of who's being elected as president, and look over the long term. And if you look at the long term, the point I try to make is it's just demographics alone. If we go back to 2010, we had about 4.5 people working for every
Mhm.
Medicare beneficiary. In 2030, that number is 2 or 1.8.
Mm.
So, we could get huge productivity gains from AI. We're still never going to make up for the fact that there's just an increasing burden of older people in the country. And over time, that burdens the entire healthcare system.
Hmm. Hmm. Yeah, it's a great point. Do do you I want to dive in. I don't want to get too much into rabbit holes here, but you talk about the fee schedule is really being kind of the major way to reduce costs, right? And it is shocking when you start to look at these numbers. And by the way, thanks for you had so many great references and so much great data in the book. I don't think most people understand that, the healthcare system outside of Medicare is charging two and a half, 250, 300%. When you go to your hospitals, that's the cost. It's not Medicare. It's 2 to 3 times the cost of Medicare.
Mhm.
Do you, but the other, so that's one way to cut costs is to reduce it down to Medicare. The other way is through value-based care, through managed care. And you talk about that in the book and even redefine that a bit or clarify what do we mean by managed care?
Mhm.
In your, again, years of experience and your review of the literature, what what do you see as the potential for managed care in the future? And again, obviously, reducing the cost will or the fee will obviously reduce the cost. But is there a role for managed care, and what's the track record in your estimation of how managed care has controlled utilization, inappropriate costs in healthcare?
Yeah, well, I would say it's there's a lot of answers to that. But I'm an advocate for value-based care or so-called managed care. I don't think there's much difference between what we called managed care in the 1990s and value-based care today, except
Hmm.
for, sort of a public relations spin on it. But basically, I think it's important for
That's fair.
the providers of healthcare to have risk for the overall costs. Because if you do that, you try to keep people healthy, you try to prevent illnesses. You try to keep people out of the hospital. So all those things are really good. The subsequent book I've written that came out last October is on primary care. And there I try to track
Mhm.
primary care practices that are really doing value-based care. I think that there's some real hope for the future there. But I would say two things about it. One is that
Mhm.
the government payers have been much more oriented towards and trying to be assertive about and cultivate value-based care than have the commercial payers.
Mhm.
So, places where you really see sort of advanced primary care, where people are taking capitation and keeping their patients healthy, almost a huge percent of that is in a managed care population, is in a Medicare Advantage population,
Mhm.
where they feel like they can really sort of take the steps they need to be able to meet the capitation. That's one thing. The government's a strong supporter of value-based care in a way that commercial insurance isn't. But also, I'm just worried, sort of having looked at it now for
Mhm.
a very long time, about how long it's going to take for us to get to significant penetration of real value-based care
Mhm.
in the healthcare system. I think that changes in financing can help with that. And I think the government is playing both federal and state governments are playing a really important role in trying to cultivate it. But it is a long haul. And you see how much easier it is for everybody to make a lot of money in a fee-for-service approach than a managed care approach. So a third book I'm working on right now
Mhm.
is on cancer care and specifically on oncology drugs. And there it's completely a fee-for-service approach. And there's almost no way to sort of break the amount of expenditures that are going into the care there.
Mhm. If you were having this conversation right now with RFK Jr., Dr. Oz, some other folks in the federal government, what would be the top two or three recommendations you would make for them now in terms of steering healthcare in the right direction for the next decade?
Well, I have to say, I think they're steering healthcare in the wrong direction
Mm.
right now, especially sort of the changes at CMS and NIH. They appear to have, they destroyed USAID.
Mm.
They've done a strong job of sort of taking down the CDC. They look like they want to do the same with the FDA. So, what I'm more worried about is how, after another 3 years of this, you go about sort of repairing these institutions,
Mm.
rather than looking for them to be sort of designers of good programs. So I'm extraordinarily disappointed with what I see. And I
Well,
think
Troy,
it's
let me just ask, let's pause there for a second. So I asked you what you would recommend, and you're saying, hey, Zev, I'm more worried about the damage that's been done and how we're going to undo the damage or repair the damage. So for folks who are listening, what is the damage? So when you say they've taken down the CDC, they're looking to do that, the NIH, they've already done that with the NIH, they're looking at the FDA. For the average American, what is the danger in, because people talk about big government, how would you very simply explain what the damage that's been done and how serious it is and the implications for the average American?
I think the implication for the average American is just basically the sort of challenge that they're making the legitimacy of expert opinion. I mean, you've got a lot of people in the administration who, especially during this sort of COVID period, felt like they were outliers and that the experts didn't listen to them and that they were treated badly. And so now they're in charge and they basically sort of want to return the favor.
Hmm.
And as a result of that, I think you've got a real slowdown in terms of the progress that NIH can make on a variety of sort of basic illnesses. I worry the FDA is starting to look like it's purely a transactional organization, and we see a tremendous amount of talent leaving both NIH and FDA.
Hmm.
In CDC, the job is already done. I mean, they've reduced the number of people who work there, and everyone else who does still work there seems to be completely despondent. And all of this is meant to sort of undermine the role that the government plays in public health and in setting authority
Hmm.
and promoting science. And so I think that's the unfortunate damage that's really being done. The most recent business about sort of reducing the number of vaccinations, the profession itself has to hold together in terms of its recommendations and hope that the healthcare system listens to expertise as opposed to this sort of political ideology that you're getting from the current Department of Health and Human Services. Having said all that, I think CMS has got some things that they seem to be interested in doing right. The people who are running CMMI are committed to value-based care still, and they're committed to two-sided risk. And I think that those things are important. They're talking a lot about sort of
Hmm.
specialist subcapitation, which is an interesting set of concepts there. But in general, what you see more of is things like the drug pricing stuff, which appears to be sort of a series of sort of PR engagements with the president rather than being anything that's substantive in terms of sort of lowering the overall costs. And these notions they bring forward about sort of creating a marketplace letting consumers choose, that
Hmm.
when you're talking about maybe somebody who decides that they're going to spend $150 a month for one of the low dose GLP-1 agonists, that's one thing. But like the kinds of disease I'm looking at right now in this cancer book, myeloma, most people are on a $600,000 a year regimen. There's no such thing as sort of out of pocket or consumer shopping
Wow.
associated with that. You need to be really thinking about the healthcare system. And unfortunately, I don't think they are.
Let us end on a, if there can be a hopeful note here. What are you encouraged by in terms of what's happening, or what are you hopeful about?
Well, this transformation book was basically a sort of desk book. I sit at my desk and write. But primary care book, which I recently finished, I went out and visited probably about 60 or 70 different clinics.
Hmm.
And the name of that book is Wonderful and Broken because the primary care healthcare part of the
Yeah.
healthcare system is broken. But there's a lot of wonderful people involved with it. And, sort of no matter where I went, even when people were feeling primary care doctors are feeling pretty burned out and upset with the system that they face, they were still wonderfully committed to their patients and
Hmm.
really doing great things and retaining what I think many of us who went into medicine, I had it when we started, which was we wanted to help other people and do good. And so
Hmm.
there's still a huge reservoir of that. And I don't think we'll deplete that, but I do think we have to learn ways to cultivate it and make it an easier job to do so people can continue to care for others.
I think you just hit the nail on the head with that. I couldn't agree more. I think the problem is never the people in healthcare. They're smart, they're dedicated, they're hardworking, they're passionate about what they do, they're professional. I think the question is, can we create a system that actually supports them as opposed to making the job more difficult? And I think we didn't get into this, but the whole issue of aligning incentives so that they're actually supporting health as opposed to blocking the achievement of health outcomes.
Right. Exactly right. Yeah.
How can people learn more about what you're working on? What's the best way to do that?
Well, I'm pretty committed to working on books now. So I guess, sort of read books. That's not the way most people get their information
No.
today. I understand that, but I'm remaining sort of solidly old school in my approach. Yeah. Yeah.
Yeah, well, I'd love to see you do more interviews and really get your ideas out there. Again, I was just really kind of I mean I knew you as an executive and as a leader, but you're a phenomenal educator and a writer. The book is just and I'm looking forward to reading your book on primary care and the one you're going to publish on cancer care. Dr. Brennan, can't thank you enough for joining us today and really appreciate the work you're doing.
Well, thank you, Ziva. I appreciate it.